Hello, good evening. This is Dr. Ayub, and I have a plan today for you that I like to go over the GYN, means pelvic ultrasound imaging techniques. Pelvic ultrasound imaging techniques. Is there any technique for this? What do you think? There should be a technique, a special technique? Yes. Why? Because not everybody will be scanned in the same ways. No. There are at least 3 different ways you can evaluate the female pelvic organs. Female reproductive organs, and not everybody will have all those 3 types, and their indications are also different. Okay, so then first of all think about it, that why it is so important. Why? Because the people says that because of the invention of the transvaginal transducer, nowadays the diagnosis of female reproductive diseases are so accurate, and their sensitivity and specificity is more than 95%. But it needs a trained operator. It needs a trained operator. What is trained operator means? It needs a trained sonographer. Those who are national standard. That means they are registered sonographers. Okay? So now when a registered sonographer with a good machine and transducer, and they do the appropriate types of protocol and approach onto the different person, especially the age group too, pregnancy status too, and the signs, symptoms. When all those are considered, so then we pick which type of examination will be done. So here I mention the types are transabdominal, transvaginal, and translabial, also known as transperineal. So transabdominal, also known as transvesical. Vesical means the bladder. Okay? So now these are the 3 types, and for each type their patient's preparation are different. Patient preparations are different. Patient preparation for transabdominal, that is called transvesical, is different than the transvaginal, and the transvaginal is different than the translabial or transperineal. And the transducer are used for the 3 different types, are 3 different types of transducer, 3 different types of frequencies of transducers are used. Okay, so it is very important to understand that how careful you have to be to select the appropriate transducer with a frequency for individual types of GYN protocols. I will also discuss about the total techniques. Total techniques, how we will perform the pelvic sonography, And I will discuss also the indications of ultrasonography for the transabdominal, transvaginal and translabial. Make sure you know that not everybody will have these three with any condition. No, there are some specific reason, a specific indication for the use of transabdominal, transvaginal and translabial. And among these three, the transvaginal is more sensitive, more accurate, and translabial is done for the lower uterine segment to see cervix, vagina, so the lower reproductive organs, okay? And transabdominal is used for, in general, we'll discuss about it. Then we will understand, we will study the transducer preparation. Transducer needs to be prepared because some transducer is going inside the birth canal. And there are a lot of germs are over there. It can be contaminated with the transducer, and the transducer needs to be disinfected. Okay? And the transducer needs to be disinfected, and precautions when you are going to prepare it for the use. Also, for the translabial approach, you need to cover the transducer too. Okay, and we're going to use the different types of transducer for each purposes. Then we will discuss about the image orientation. Image orientation means how to study the image when you take the picture. Where is the anterior, posterior, superior, inferior, right, left? Do you think for each approach all the orientations are the same? No. Transvaginal orientation is different than the transabdominal and translabial. You need to learn because you need to read the images. So then we're going to discuss about the scanning method. Scanning method, and when you scan, so then what would be the patient's position? What would be the instruction? We're going to discuss about the protocols and why that protocol, that image is needed. Keep that in mind. There are the universal images for the GYN protocol. What does universal means? It means that all over the world they practice in the same way. And when some people will observe the images from other countries, so that they can read it, they can understand that they are doing the same protocol as we are. Okay, that's why you need to know the scanning method, universal method. Then transducer disinfection. We need to learn how to disinfect the transducer, because these transducers are going to be contaminated with germs, and we cannot use that transducer without preparation, without cleaning the transducer for the germs, or sterile the transducer, because there are some notorious bugs like HIV can also be transmitted from one person to other person, especially by the transvaginal transducer. And it has a separate guideline for disinfection, and it has a separate room for making the transducer disinfected and sterile. Okay, so it is very important. Then finally we will learn that how to report. Okay, so we're going to learn the reporting. How are we going to report? Our reporting must have the information about the LMP, first day of last menstrual period informations. Then our reporting should correlate with the clinical sign symptoms. Example, patient saying that I have too much bleeding, irregular bleeding. So you are thinking that that may go with the something wrong in the uterine endometrium. So, and you found something, but you are not describing that. You are describing with something else. So, patient symptom is related with the endometrium, but you are describing something. No, it's not. It should not be. Your reporting should correlate with the clinical findings. It is very important. You need to understand that, so that the clinician who is treating the patient, when they are going to see the reporting, and they will understand, yes, so this report correlates with my physical examination, correlates with the patient's sign symptoms. And we have to indicate, is there any previous scanning report in the patient file. So patient file or folder we need to check. You need to check for, is there any other modalities done for this patient, and when it is done, what was the report. And you have to compare your report, because the protocol is done the same, and now you have to compare your findings with the previous findings. Okay, so these are the things we're going to discuss, and we're going to give you the protocols, and I will discuss that why this image is taken. It has a clinical values. Okay, so now let's talk about the transabdominal. Transabdominal ultrasonography for the GYN. It is, this approach is used through the bladder, and the bladder needs to be full. Okay, so preparation for this transabdominal preparation is very simple. How? Because the ultrasound will be done through the bladder, and bladder is anterior to the uterus. When the bladder is full, so the fundus of the bladder or apex of the bladder should come up to the fundus of the uterus. So then bladder will be distended, maybe 400, even 500 cc of urine is collected in the bladder, and as bladder is anterior to the uterus, and the uterus is 60% uterus is anteverted like this, and this is bladder, and bladder is getting full, and it makes the uterus straight like this, and the beam is coming at 90 degree. Oh my God, you understand that? Yes, when bladder is really nice full, uterus is no more like this. Uterus is getting like this, and the bladder is here, and you are scanning from here, you are getting at 90 degrees straight line onto the endometrium. So you will see the full thickness of the endometrium because the reflection is best at 90 degree. Okay, that's why we need a full bladder. And the full bladder also help to move the intestine and the bowel. Bowel has the gas, intestine and the gas in the intestine, that is bowel. Bowel has the gas. If the bladder is not full, so all the small intestines, coils or loops will come and occupy the lower pelvis or occupy the pelvic cavity. And it causes dirty shadow, snow storm appearance, dirty shadow. That is the artifact. And part of the uterus and most of the ovaries will be obscured so that you cannot see. And your diagnosis will be half done. So it is happening on and off. Even though the bladder is full, you are scanning, sometimes you don't get the ovaries. Maybe one you got, another you did not. You did not. Sometimes there is a pathology in the uterus because of the obscuring due to the bowel gas. There are some pathology in the fundus or in the cervix area are missing. And that patient needs transvaginal ultrasonography. That's why nowadays for every clinic they do pelvic ultrasonography in both ways. They will do with a full bladder or partial full bladder, whatever it is. They will take images through the bladder transvesically. Then they will ask patient to go to the bathroom, empty your bladder and come back. And when they come back, so bladder still have a little urine that works as a landmark. Then they will do the transvaginal ultrasonography and they will get everything very clearly. Why very clearly? We're going to discuss. Okay? So now I was talking about the bladder full. And the bladder full also work as you can see, you can visualize the bladder. You can see the bladder, posterior wall of the bladder. Is there any indentation? Because some of the fibroid, subserous fibroid or pedunculated fibroid can make an indentation onto the posterior wall of the bladder. And you can notice it and you can identify the pathology. Okay, so what are the advantages? It makes for the full bladder, it makes the uterus from the antiflex to antiverted and makes a nice at 90 degree orientation so that you can see the full uterus along with the full thickness of the endometrium. Number two, it displaces the bowel with their gases so that window is more better, clear. And you can see any pathology anterior to the uterus, posterior to the bladder by looking at the indentation. You can figure it out. There is some pathology like fibroid on the uterus. So the bladder full is a mental peace. And bladder full will give you very clean window. Very clean window, because the urine in the bladder causes a posterior enhancement. And you know, the enhancement is a brightness. There is no shadowing. So there is no chance of obscuring any posterior organs. So now, how are we going to pull the bladder? That is very important. Usually the rule is the patient will drink the water 32 ounces is a 1 liter. They will start drinking, but they have to finish 1 hour before the exam time. So if the exam time is 9 in the morning, so she has to stop drinking at 8 a.m. So that 1 hour is enough time that water will go into the stomach. From the stomach it will go into the intestine and absorbed. It will go to the blood, and the blood will be filtered out by the kidney, and urine will be there. Now, in your lifetime you will see a lot of people, they did not drink water. They drank coffee, tea, Snapple, juices. Okay? And they came to you. But no, you cannot drink that fluid that has sugar. Why? It will cause the osmotic diuresis. That means the time at which the bladder should be full, bladder will be full before that. And patient will come to the clinic, and they will say, oh, I have another 15 minutes, 30 minutes to wait, but my bladder is super full. What's going to happen then? When the bladder is super full, they cannot hold the urine. They need to go to the restroom. But you know, it's not like that. I'm very full. I have 2 more patients before me. Can I go now? No. You cannot superset. So now, what are you going to do? They will say it's your choice, but one thing we can do, what? Take a cup. They will give you a cup, say 8 ounces cup, and they will ask you, okay, just empty 2 of this cup. 2 of this cup, 16 ounces of, and patient, it is very hard for a female to stop the urine. When they pee, to stop the stream is very hard. If you just ask, stop it, no, they can. But if you give the cup, they will be more mentally alert. They can. They can stop. And they will come back to you. And they say, now I'm relaxed, I can wait half an hour. So that is one way. Another way is, okay, go to the bathroom or go to the home. But if you empty your bladder, it's going to take another at least 1 hour or 1.5 hours. Then you will be at the end of the list. Or you can make a reschedule. But reschedule is very tough. You already took the day off or half of the day off. You cannot take another day off. That's why they are instructed, do not drink sugary liquid. Okay? Just plain drinking water. Okay? This is important. So now, how I will drink the water, how I will fill up the bladder. Is it drinking always? No. Some patient you will see, they get nauseatic, they cannot drink water that much. Some patient you will see, they are instructed not to drink water because the patient came to the ER, emergency room, with some acute abdomen, acute pelvic, and nobody knows, and the patient is also pregnant, and it could be an ectopic pregnancy, ruptured ectopic pregnancy. Patient may need to be sedated, so, but I need to check the uterus, I need the full bladder. We cannot ask patient drink water because this patient may need to go to the OR. So in that time, what are you going to do? It bladder can be filled in with the catheter. It could be plain catheter or it could be by the Foley catheter. Foley catheter, you can inject the fluid to make the bladder full, or with the Foley catheter, with the tube, you can hang up the saline bag, bladder is getting full. Okay, so in that way, they can make an arrangement for bladder fullness. Sometimes you will see that transvaginal ultrasonography is contraindicated. Patient has to be scanned through the bladder, no matter what. So, I need the full bladder. Sometimes you will see, okay, bladder, you are not full, okay, no way, no problem. Let me couple of images through you and I will see it is inadequate, it is limited. So I will ask you, go to the bathroom, empty as much as possible, come back.